So, good evening, everybody, and we have a very important session. And I would like to thank Lupin at the offset for bringing in this session, even if this is quite late for us in India. But I think the session is extremely important. More important is the speaker. So, we have Professor James Januzzi from the Harvard Clinical Research and clinician. So, he's both interested in heart failure research and heart failure as a subject. He has several manuscripts, actually more than 600 to his credit, and he's a leading author in many of them. And we have a very important topic we discussed today. We have heart failure as to the acute decompensated heart failure as the primary indication for discussion today. So as we know that acute decompensated heart failure is the commonest way in which a heart failure patient actually dies. We also know that acute decompensated heart failure is really difficult to treat. We know the controversies and when to start what. We have three primary drugs which reduce mortality. We have beta blockers, we have ARNI, we have SGLT2 inhibitors. And our inhibitions of starting these three drugs at the offset in an acute decompensated heart failure patient is huge. Beta blockers we don't want to start because the patient is in heart failure. ARNI, we think the BP will come down significantly and the kidney will behave in a difficult fashion. Dapagliflozin may cause ketosis in an acutely ill patient. So what to do and when to do? So what should be the order? Should we start all three? Should we start none, wait for 2 weeks? We have enough trials to help us understand that, and we don't have a better person than James Januzzi to help us understand it. Professor James, it's your game now. We'll have your talk for half an hour. I understand it's a pre-recorded talk, and we'll come back to you with questions and some discussion at the end of this half an hour discussion. So we'll put your pre-recorded talk right on.
Thank you very much for the kind introduction. I'm thrilled to be here today, and I just wish that I could be there in person. Hopefully next year we can be together for your very important meeting. I'm grateful to be able to speak today on hospitalization as an opportunity to optimize heart failure care. These are my disclosures. I am an industry-sponsored clinical trialist, so it's important to keep that all in mind during my discussion. So why would we discuss hospitalization as an opportunity for optimizing care? Well, it speaks in part to the global gaps in heart failure therapy that exist for our patients. And it also reflects the fact that heart failure is a progressive disease. So with progressive cardiac injury and cardiac dysfunction, we can appreciate worsening myocardial dysfunction, leading to repeated decompensations, repeated hospitalizations. And in each of these decompensation events, there's worsening functional capacity and progressive likelihood towards the risk for dying. So opportunities to optimize care, as well as to subsequently prevent these future decompensations, represent an important goal for us who care for patients with chronic heart failure. And indeed, there's no better place to optimize management of patients with heart failure than at the time that they might be admitted to the hospital. There are basically two major opportunities that we can see at the time of hospitalization. The first is to establish best practices for inpatient drug therapy, but also, and very importantly, to optimize guideline-directed medical therapy for the outpatient environment. And really, when you think about it, as this figure shows from the American College of Cardiology Expert Consensus Decision Pathway document, when you really think about it, thinking about the hospital and the home as two different environments really doesn't help our patients very much because the two are very connected, right? So the hospitalization of a patient with heart failure is an ideal moment to initiate the optimal care that they deserve for the outpatient setting. Of course, to address the first point, best practices for inpatient drug therapy, this is something that I think has become rather simple in many ways, which is because of the fact that we don't have any intravenous therapies other than nitrates and diuretics for management of the most acute patients coming in with volume overload. Really, it comes down to identifying the hemodynamic and congestion status of the patient. So if they're warm and wet, which is the way most patients with acute heart failure present, these are patients who should just receive intravenous diuretics and continuation of previous guideline-directed medical therapy, and maybe nitrates to help improve symptoms, but a rapid transition should be made towards newer therapies for acute heart failure, as I'll talk about. It is the lesser common cold and wet patients who might receive an intravenous vasopressor or inotrope, or an intravenous inodilator, but these are patients that are rather rare. Really, the great majority of our patients have good perfusion, so they're warm, and congestion, so they're wet. And these patients should receive intravenous diuretics, and as was shown from the dose study, 1 to 2 times the home diuretic dose administered intravenously and given every 8 to 12 hours is the way that we do it at the Massachusetts General Hospital Heart Center. And it allows for rapid trajectory towards improvement in most cases. But here's the thing, and I think it's really important that we move beyond the use of just treating acute heart failure with diuretics. Because importantly, as I've already said, given the link between the hospital and home, an inpatient treatment algorithm should not emphasize only diuretic therapy for our patients with heart failure. And indeed, an inpatient algorithm should have a rapid transition towards optimizing previous guideline-directed medical therapy and initiation of newer therapies, specifically angiotensin receptor neprilysin inhibitors or sodium glucose cotransporter 2 inhibitors for patients with acute heart failure. In addition, I'll talk about the use of intravenous iron as well for our patients. So, the majority of what we'll discuss is based on the optimization of outpatient heart failure care, as emphasized in the just published update to the 2017 American College of Cardiology Expert Consensus Decision Pathway document focused on optimal heart failure care. And this document, just published in 2021 in January, I served as the vice chair of the writing committee, and am really pleased with how it covers a substantial amount of information regarding not just medical therapy, but the global optimization of management of patients with heart failure and reduced ejection fraction. There are 2 major changes in the Expert Consensus Decision Pathway document that focus on frontline medical therapies. The first is the elevation of sacubitril valsartan as the preferred first-line renin-angiotensin inhibitor, and as well it adds sodium glucose cotransporter 2 inhibitors as a foundational therapy for medical management. Now, how do these drugs fit in among patients with acute heart failure? Well, certainly we now have data regarding the use of angiotensin receptor neprilysin inhibition in patients with acute heart failure from at least 2 studies. The first is the PIONEER study. So PIONEER was a randomized controlled trial of patients with New York Heart Association class 2 through 4 acute heart failure with reduced ejection fraction, randomized to receive enalapril or sacubitril valsartan. At randomization, these patients were considered eligible if they had a systolic blood pressure greater than or equal to 100, no intensification of IV diuretic use. And I'm going to talk a little bit about how we do this at the Mass General Heart Center. Certainly no IV inotropes or inodilators, and no nitrates within the last 6 hours. So importantly, these are patients that are warm and wet who have stabilized from their initial decompensation. The primary endpoint of the PIONEER study was a proportional change in N-terminal pro-BNP concentrations, but they also evaluated the incidence of major cardiovascular events within the first 30 days of the study. And this is important because when you look at the primary endpoint, of course, the NT-proBNP was substantially lower in the sacubitril valsartan arm, but when we look at the serious composite endpoint of death, heart failure rehospitalization, left ventricular assist device placement, or transplant listing, we can appreciate that within a 30-day time point and extended out to 60 days from randomization, there's already a dramatic reduction in the primary serious composite endpoint, which was driven by reductions in rehospitalization. Now, again, let's go back to one of my earliest slides that showed that with each rehospitalization, there's a continuous decline in functional capacity and a higher likelihood for mortality in our patients with chronic heart failure. So this result is critically important to emphasize, because within a 30-day likelihood for a rehospitalization, there's a nearly 50% reduction, a 44% reduction in the likelihood of this event occurring. That's absolutely staggering and really demonstrates how and why we should initiate sacubitril/valsartan among patients with acute heart failure. We have more data from another study, the transition study, that helps to provide even further support. One very important aspect of Pioneer was that it included patients that were de novo, they had not previously seen a RAS inhibitor, as well as patients who were on either an ACE inhibitor or ARB at presentation. The transition study did the exact same thing, and it enrolled patients who had been admitted to the hospital with acute heart failure, regardless of their background strata, and then randomize them to either pre-discharge initiation or post-discharge initiation of sacubitril/valsartan, titrated up to the investigator's discretion. And the discharge came within 2 weeks from presentation typically. Here are the primary and secondary endpoints, just showing that initiation pre-discharge in the dark green is very feasible and quite well tolerated overall for those patients that presented with acute heart failure, rather than deferring it to the outpatient setting. Furthermore, when we look at the de novo initiation, these are patients who had never seen an ACE inhibitor or angiotensin receptor blocker. We can appreciate that, if anything, the likelihood for achieving target doses in those patients was slightly higher, which is actually reassuring. And notably, the most relevant adverse events were, in fact, in most cases, lower among those patients with de novo initiation. Furthermore, when we look at outcomes, we can appreciate that the de novo patients were typically a much lower risk than prior heart failure patients that had previously been treated with an ACE inhibitor or ARB. This is critically important and really addresses an important aspect of the discussions that we have when a patient presents with new onset heart failure in the hospital. So some people ask, well, shouldn't we start an ACE inhibitor or angiotensin receptor blocker in these patients? And based on the results from Pioneer and from Transition, the answer is no. Any patient with a reduced ejection fraction with acute heart failure, regardless of their pre-treatment with an ACE inhibitor or ARB, should receive sacubitril/valsartan in the course of their hospitalization. Mechanistically, we have some good answers as to why this may be. We performed the PROVE-HF study, which was an outpatient chronic heart failure study, where we took patients with chronic left ventricular dysfunction and class 2 through 4 heart failure and placed them on sacubitril/valsartan, measuring NT-proBNP levels and monitoring their left ventricular size and function over a 1-year period. We observed in all subjects a 30 to 35% reduction in N-terminal proBNP values. These reductions in NT-proBNP were strongly, very significantly associated with reverse cardiac modeling. And this occurred despite the use of a RAS inhibitor in more than 80% of patients at baseline. But notably, as I'll show you in a moment, those patients that were de novo initiations had the greatest improvement in ejection fraction. And indeed, when you look at the largest responders, about 25% of the patients in this study had an ejection fraction increase of more than 13%. And of course, along with improvements in ejection fraction, we see reductions in left ventricular volumes. As well, we see improvements in left atrial volume, improvements in diastolic function, and a reduction in left ventricular mass index as well. So really a nice example of reverse cardiac remodeling. But we get back to this question about what about patients with new onset heart failure? And on the leftmost part of this slide, you can appreciate that those patients with new onset heart failure, those patients who had not previously been treated with an ACE inhibitor or an angiotensin receptor blocker, these patients had the greatest amount of reverse cardiac remodeling with the largest improvements in ejection fraction and the largest reductions in left ventricular and left atrial volume, as well as improvement in diastolic function. So this really says in our patients with acute heart failure that are eligible for a vasodilator that they should be placed on sacubitril/valsartan regardless of a background of prior ACE or ARB therapy before presentation. In addition, treatment with sacubitril/valsartan causing reductions in NT-proBNP and greater reductions in left ventricular volumes is associated with the largest improvement in prognosis among patients with chronic heart failure. So treat these patients early, get their NT-proBNP down, and you will see reverse remodeling and better outcomes. So I've focused largely so far on reduced ejection fraction, but it's important for me to mention that there are now emerging data regarding sacubitril/valsartan for managing patients with preserved ejection fraction. And importantly, the Paragon study recently examined the randomized comparison of sacubitril/valsartan versus valsartan in patients with chronic HFpEF. This was a study of patients with an ejection fraction greater than or equal to 45%, elevated natriuretic peptides, evidence for structural heart disease, and who were congested requiring diuretic therapy. Following a double-blind treatment period comparing sacubitril/valsartan to valsartan, the primary endpoint of total heart failure hospitalizations and CV death over a period of about 3 years was read out. And this is really important because I'm now talking about a subgroup analysis of Paragon, which focused on those patients that were previously hospitalized prior to screening. This is a really interesting analysis. So a substantial number of patients, all the way to the left of your screen here, were included in the Paragon study during their hospitalization or soon thereafter. So if you look at the first 30 days since hospitalization, nearly half of the patients actually were recently hospitalized. And when we look at the risk for the primary endpoint related to the proximity to hospitalization, we can again see that as with reduced ejection fraction heart failure, the incidence rate for the adverse outcomes in Paragon was essentially linearly associated, opposite from those patients for those patients with a recent hospitalization, such that those who were just enrolled in the hospital had the highest event rates. So again, hospitalization for heart failure leads to more hospitalization for heart failure. And when we examine the impact of sacubitril/valsartan in these patients versus versus valsartan, we can appreciate that those patients that were enrolled during their heart failure hospitalization or within 30 days, that treatment with sacubitril/valsartan was actually superior to valsartan alone, with a gradient towards reaching a less obvious benefit when you get to much more stable patients who had never been hospitalized for heart failure. This really confirms a couple of important things. First, there's a great heterogeneity in risk among patients with preserved ejection fraction heart failure. Second, treatment with sacubitril/valsartan for those patients that are congested, requiring hospitalization, would be expected to reduce the risk for the primary endpoint, and actually with an absolutely larger risk reduction of 6.4% among those patients recently hospitalized, as opposed to those patients who were hospitalized outside of 30 days or even longer. So once again, what this comes down to is a real opportunity for initiating angiotensin receptor neprilysin inhibition among patients that are hospitalized for heart failure, regardless of their ejection fraction. It provides the opportunity to initiate important therapies with a substantial absolute risk reduction in this environment. Okay, so how do we do this at the Mass General Hospital Heart Center? Well, the first thing is when a person with acute heart failure is hospitalized, what we typically do is we look at their background medical therapy. If they're taking an ACE inhibitor and we consider them eligible for sacubitril/valsartan, what we do is we actually switch them from an ACE inhibitor to an angiotensin receptor blocker on admission while we're diuresing the patient. Why would we do this? Well, I remind you that you need to get a patient off of an ACE inhibitor before starting sacubitril/valsartan. So what this does is it gives us a head start getting the ACE inhibitor out of the system so we don't have to wait 36 hours. And after the patient has decongested adequately, we then switch them directly to sacubitril/valsartan. The other thing that we do is we do not diurese the patients as aggressively before starting sacubitril/valsartan because we have learned that by getting too aggressive with intravenous diuretic use, the risk for hypotension is somewhat increased. All right? So we are quite enthusiastic about the use of sacubitril/valsartan in our acute heart failure patients. And as sacubitril/valsartan will be approved for preserved ejection fraction heart failure imminently, we expect we will be using it for this patient population as well. Now, I mentioned that there's another medication class in the expert consensus decision pathway document that has recently been adopted for the care of chronic heart failure, and that is the sodium glucose cotransporter 2 inhibitor, or SGLT2 inhibitor class. This is an important subject because SGLT2 inhibitors work very nicely together with sacubitril/valsartan. And so where are the data so far for patients in acute heart failure versus chronic? Well, there are a couple of studies now that have recently reported out. The EMPA response acute heart failure study examined the impact of empagliflozin in patients with acute heart failure, showing no difference in dyspnea, no difference in diuretic response, no difference in length of stay, and no significant difference in the NT-proBNP values. So there's a lot of actually differences in what we see when we treat patients with sacubitril/valsartan and an SGLT2 inhibitor in the hospital at least. But very nicely, if you look at the secondary endpoints, treatment with empagliflozin was safe and well tolerated, which is important, and there was a trend towards improved outcomes among patients early on once again. So this really, again, identifies the hospitalization period as an opportunity to get a medication that we know works in the chronic outpatient setting and may have some impact on hospital outcomes on board at the same time as starting sacubitril/valsartan. More recently, the Soloist study examined an SGLT1/2 inhibitor, so this is sotagliflozin, among patients that had been admitted to the hospital with worsening heart failure. And in this setting, the investigators did pre-discharge oral therapy optimization, just like I'm talking about, which is getting the patient onto an ARNI, optimizing their beta blocker, optimizing their mineralocorticoid receptor antagonist, but then adding sotagliflozin to patient management at this pre-discharge setting. The outcomes of the Soloist study really were quite dramatic in that adding sotagliflozin was associated with a 33% reduction in the risk for the primary endpoint, and the benefits were seen very early. So once again, just like in Pioneer, a very early effect, significant by 30 days, with a number needed to treat quite similarly to the Pioneer study. What does this say about how we should be managing our patients? Again, I will make the point one more time. Hospitalization is an ideal moment to initiate sacubitril/valsartan, and now I would argue an SGLT2 inhibitor. Why is this? Because it helps to reduce early post-discharge events. We have no therapies other than these two drugs that have been proven in randomized trials to reduce the 30-day rehospitalization risk among patients with heart failure. Now you might ask, well, is this a reduced EF or preserved EF effect? And here are the data from Soloist and another study called SCORED, pooling their data to look at patients with preserved ejection fraction, now showing, similarly to what we saw with sacubitril/valsartan, a reduction in risk for those patients with preserved ejection fraction. So this is really, I think, further evidence showing how we now have a couple of more weapons in our armamentarium for treating patients with preserved ejection fraction. Now, my friends, this is not an either-or decision. In other words, you should not be saying, well, I'm going to use one drug over the other. You should not be saying that you prefer one over the other, because they are additive. These are the data now looking at the combination of sacubitril/valsartan with an SGLT2 inhibitor in a meta-analysis, just showing that those patients with a background of ARNI therapy treated with an SGLT2 inhibitor had similar reductions in risk from being treated with the SGLT2, and the other way around also stands. So these drugs are not an either-or. They should be used together. Lastly, in the patients that are hospitalized for acute heart failure, we have opportunity to optimize one other important aspect of their heart failure care, specifically iron therapy replacement. So why would we think about administration of IV iron for our patients with acute heart failure? Well, once again, we want to think about where the common comorbidities are in our patients with heart failure. And when they're hospitalized, you have a perfect opportunity to optimize their medical care. So iron deficiency is common in patients with heart failure and associated with poor exercise capacity, worsened health status, and importantly, an increased risk for hospitalization or death. It's been shown in stable heart failure patients that treatment with intravenous ferric carboxymaltose, or FCM, improves physical performance and quality of life. But the question is, should we evaluate our patients hospitalized with heart failure and treat them with IV iron as a part of the standard hospitalization for acute heart failure? And the AFFIRM AHF study examined this question. So Professor Ponikowski designed this study, which randomized patients to either ferric carboxymaltose, FCM, versus placebo usual care in patients with acute heart failure. The inclusion criteria for these patients, and this is important to remember when you're evaluating your patients. In order to be included in this study, patients obviously needed to have acute heart failure, but remember the iron deficiency inclusion. So a ferritin less than 100 or a ferritin between 1 and 300 with a TSAT, transferrin saturation, less than 20. Right? So these are patients that have evidence for iron deficiency, but aren't bleeding or have another reason for this finding. In the study, patients were treated with FCM depending on their baseline hemoglobin. So for those patients with a normal hemoglobin, they received 500 milligrams of FCM versus placebo. If their hemoglobin was less than 14, then they received 1,000 milligrams versus placebo. And then on week 6 in follow-up in the office, they received a second dose if appropriate. The outcomes of the AFFIRM AHF study demonstrated 372 total events. This is total hospitalizations or CV deaths in the placebo arm, and 293 in the FCM group, leading to a 21% reduction, which did not reach nominal statistical significance. However, quality of life improved, exercise capacity improved, and importantly, I don't think you can really say that this study was negative when it identified an opportunity to get a therapy started during the hospitalization, which could then more easily be completed during the outpatient follow-up. And this gets back once again to the point that I was making at the very beginning of this talk, which is that inpatient care is a prime opportunity to improve outpatient management. It again allows us to establish best practices for inpatient drug therapy. This includes optimizing diuretic use, initiation or titration of other guideline-directed medical therapies, and initiation of sacubitril/valsartan primarily, as well as SGLT2 inhibitors, and consideration of intravenous iron for those patients that are iron deficient. Why would we consider all of this? Well, it optimizes the opportunities to get patients on ideal guideline-directed medical therapy when they are discharged. Once again, There's no reason to separate the hospital from the home in this setting, and the hospitalization is the ideal moment to get optimized GDMT in place before the patient is discharged. We remind you once again that in the 2021 update of the expert consensus decision pathway document, sacubitril/valsartan, so-called ARNI first, is now the upfront RAS inhibitor for patients with reduced ejection fraction. So we've moved from the use of the term ACE-ARB-ARNI to now saying ARNI-ACE-ARB. And importantly, patients at this stage that are eligible for sacubitril/valsartan should be treated with it as a first line, regardless of whether or not they've seen an ACE inhibitor or ARB before or not. In addition, sodium glucose cotransporter 2 inhibitors are now part of the foundational medical management of our patients with chronic HFrEF, and certainly with emerging data in HFpEF for both therapies, I think we can be really optimistic about the potential role of just a more straightforward management strategy for our patients with acute heart failure. Lastly, when we think about the 4 pillars, MRAs, beta blockers, SGLT2 inhibitors, and now as first line, angiotensin receptor neprilysin inhibitors, it's important to remember all of the other therapies that we may wish to consider for our patients to either improve quantity of life or improve quality of life. And I've shown you data today regarding the use of IV ferric carboxymaltose in our patients with a ferritin less than 100 or a TSAT less than 20%. So in conclusions, ladies and gentlemen, I'm really grateful for the opportunity to speak today, and I look forward to a great question and answer session. Important points to reemphasize: hospitalization provides an ideal venue to reveal and optimize guideline-directed medical therapy for heart failure. Beta blockers, MRAs, these should be optimized with beta blockade optimized after decongestion, MRAs probably added in the midst of decongestion. Any patient with reduced ejection fraction should be changed to sacubitril/valsartan, and if possible, initiated on an SGLT2 inhibitor when they're hospitalized for acute heart failure. The logic behind this is both drugs reduce the 30-day rehospitalization risk, contain myocardial injury, reduce congestion, and improve quality of life. We have no definitive strategy for HFpEF at this point. However, MRAs are likely to increase in use in this patient population, with sacubitril/valsartan almost certainly about to receive approval by the United States Food and Drug Administration for heart failure with preserved ejection fraction. And sodium glucose cotransporter 2 inhibitor data are on their way. Lastly, do not forget to seek and treat iron deficiency. You can initiate the process in hospitalization. You can finalize it in the office, reducing the 2 infusions for the office down to 1 if you start it in the hospital. So with that, I will stop, and I look forward to a great discussion. Thank you so much for the invitation.
Okay, Professor Januzzi, it was one of the best lectures that I heard on acute decompensated heart failure. We have a great discussion to look forward to it. I'll pose some practical questions to you, which we face every day. Treating acute decompensated heart failure is a tough job. And, these trials, both Pioneer and Transition, excluded patients who had blood pressures less than 100. Pioneer was 110. Transition was 110 and Pioneer was more than 100. There's a significant number of patients who have blood pressure less than 100 pre-discharge. They may be doing well, they seem all right, but the pressure is less than 100. And I would say that at least 30-40% of the patients are in that range. What do you do to these patients? Because the trials don't answer it.
It's an excellent question. And first of all, I want to thank the organizers for having me join the meeting today. And thank you for staying up so late, for the opportunity for us to speak. So it is a major issue, and there's no question that not every patient with acute heart failure will be able to be treated with the full list of medications that we hope to try to use in them. One very important strategy that I recommend is to ensure, first of all, that the patients are not over-diuresed before they are initiated on the newer therapies. One thing that was really striking to me was when we first started using sacubitril valsartan in our patients that had pulmonary artery catheters in place, is the dramatic reduction in filling pressures that these patients would develop on their first dose of sacubitril valsartan. So one lesson learned is that rather than diuresing the patient until they are absolutely dry as the Sahara Desert and then starting sacubitril valsartan, to actually slow down on intravenous diuresis well earlier than we might otherwise have done before beginning them on sacubitril valsartan. So that's one important tip. Another is to seek and remove medications that lower blood pressure that may not have a benefit in patients with heart failure. And this is extremely common, as it turns out. So for example, in patients with heart failure that have hypertension, they might be treated with calcium channel blockers, alpha blockers, non-loop diuretics. All of those medications should be removed. Men who are being treated for an enlarged prostate may be on alpha blockers, which also similarly lower blood pressure. And we often don't think about that, in fact, when they're being treated with a medication like tamsulosin, which is used in the United States for urinary retention. That has a potent blood pressure lowering effect. And so removing those medications is also very important. Lastly, one of the strategies that we've been trying to use lately is lowering the doses of guideline-directed medical therapy in other classes in order to allow all 4 of the major classes to be started. So rather than a huge dose of sacubitril valsartan and no beta blocker, no MRA, what we're trying to do is find lower doses of medications that have the most effects on blood pressure so that we can get all 4 of the major classes started.
So in our practice, we have used doses like starting dosage of 25 milligrams twice. That's half of a tablet. Have you tried that? Because this is not recommended, but sometimes we feel that his blood pressure is 90, 95. I can't give him the dose, and I start with that. And sometimes they do tolerate and come back, and then we gradually increase it to the higher doses. Have you tried that dose? Because I'm told that this is not the right dose to start with.
This is the art, right, of medicine, right? And if you are able to initiate at that very low dose, but then eventually increase, then the patient will benefit. The goal, however, is to always plan on increasing the dose. You don't want to leave them on a non-data supported dose of the medication. I'll remind you that in Pioneer, in Transition, even in the Paradigm study, many patients ended the trial on doses lower than the target. And the benefit in, for example, Paradigm among patients that were down titrated to lower doses was still greater for those patients treated with sacubitril valsartan than those patients treated with an ACE inhibitor. So what this says is that being on an ARNI, no matter what the dose, is probably better than being on an ACE inhibitor or an ARB. The other point that's by no means an endorsement of lower doses for sacubitril valsartan is that when the drug was first developed, the drug maker, Novartis, skipped over phase 2 trials and went straight to Paradigm, the phase 3 trial. So the dose that we use for sacubitril valsartan actually has never been prospectively validated as being the correct dose, and it may actually be much higher than we need. Giving some support to this is the fact that in the PROVE-HF study, we found that patients on lower than target doses actually had just as much reverse remodeling as those patients who were titrated to the target dose. Stated, in a simple way, always try to get to higher doses, to target doses, but if you don't, some ARNI is better than no ARNI alone.
Right. And now, let's say you initiate ARNI in the hospital. Would you like to observe them for a couple of days, or do you think it's time to discharge them immediately after initiating ARNI on them?
Yeah, so thank you for that question. I typically start ARNI early in the hospitalization, so we have more time to watch and make sure that they don't have problems with hypotension. I do not up-titrate. I typically start at the low dose and then finish adjusting the other guideline-directed medical therapy. On the last day or two of discharge, I will also add an SGL and make sure that the patient's perfusion is fine, that there's no obvious risk for development of ketosis, and also to ensure that they're on a stable diuretic dose. I feel comfortable discharging the patient with only about a day or two of observation on an SGLT2 inhibitor because we know that these drugs are rather safe. And as well, we also tend to see our patients who we do this kind of therapy within 1 week after discharge.
Right. There are some patients who may be on RD and now come with acute decompensated heart failure. So what is your approach? Would you continue the RD and add diuretics, IV diuretics, or you would de-escalate the dose and then come back to the same dose, or you would increase the dose when they are admitted if the blood pressure permits?
Excellent question. I follow a don't start, don't stop approach when a person is acutely admitted. So if they're on a dose of sacubitril/valsartan, I don't change it, but I will apply carefully intravenous diuretic in those patients because obviously their filling pressures are elevated. Once they are more stable, I might make adjustments, particularly if they're hypertensive. I might increase the drug. I try not to reduce or remove sacubitril/valsartan if I can avoid it in that setting. If there are some data, in fact, from Paradigm showing that patients that were admitted during the Paradigm study on sacubitril/valsartan had a better prognosis than those patients that were admitted to the hospital on an ACE inhibitor, on an allopril. So we try to continue it as much as possible in that setting.
Right. Now, as you said, there are a lot of patients who would have pulmonary artery pressure monitoring during their acute decompensated heart failure. So did you find any difference in patients who have very high baseline PA pressures and the response to RD? Was it better than those who had borderline PA pressures because they are likely to be more sicker?
Oh, there's no question. I think that understanding the physiologic effects of sacubitril/valsartan is really important. You're sitting in your cath lab right now, for example. When our patients with pulmonary artery catheters get initiated on sacubitril/valsartan, even if they were taking an ACE inhibitor or ARB before being switched over to sacubitril/valsartan, their filling pressures will go down by 30 or 40%. I mean, it's a really profound reduction. And so in those patients with a CardioMEMS device, for example, we often make adjustments in our medications in those patients if their pressures are elevated on the basis of their GDMT rather than going with changes in diuretic. So we'll increase their sacubitril/valsartan, we'll increase their spironolactone. Notably, there are data that were just published 2 days ago in Circulation showing that SGLT2 inhibitors also lower pressures as monitored by the CardioMEMS. So again, the CardioMEMS device or pulmonary artery pressure monitors in general give us an opportunity to optimize guideline-directed medical therapy rather than optimizing diuretics. The key always is to try to get the diuretics to the lowest possible doses whenever possible.
So I'm going back to the same slide where sacubitril/valsartan versus valsartan in patients who had admission within 30 days showed benefit. Patients who had admission beyond 30 days did not show any benefit, which is kind of a paradox. So they should also have shown benefit. After all, does it mean that it's not a good drug to start in the chronic heart failure? What is it? I'm really confused about that slide.
It's interesting, isn't it? Yeah. So I would suggest that you look at the totality of data in that slide, which is to say that in patients that were hospitalized within 30 days, yes, there was benefit. the further away from the hospitalization you get, the benefit begins to drift back towards no obvious benefit. The only group I would say there was absolutely no clear benefit were patients with heart failure and preserved EF who had never been hospitalized, a very stable population, right? So those are patients who may very well profit from being on an ACE inhibitor or ARB, and you may wish to wait until the patients get to a point where they develop evidence for congestion, RAS activation, and the risk for hospitalization. So I wouldn't say that patients outside of 30 days don't benefit, but it's a gradient of benefit, right? And so it really speaks more to the physiology in patients that with preserved EF who are at risk for hospitalization. So RAS activation, elevation in markers of congestion, a higher NT-proBNP, physical exam findings consistent with congestion. Those are the patients who most likely benefit the most.
And what would you think that which patients with heart failure with preserved ejection fraction would be your choice to treat with an RD?
Yeah, great question. So I can tell you, the United States Food and Drug Administration is currently evaluating sacubitril valsartan for HFpEF, for preserved EF. And on the basis of the Paragon study, I think it's quite logical to expect that the approval will be for people with heart failure with preserved ejection fraction and an ejection fraction below 55%. If you look in the Paragon study, in terms of subgroup analyses, the most obvious benefit was seen in people whose ejection fraction was at or below 57%. So 55, I'm just giving you a rough estimate. In addition, women seem to benefit more than men, but that may speak more to the mechanisms of heart failure in heart failure with preserved ejection fraction being more common in women, right? So if you look at the demographics of patients with heart failure and an ejection fraction below 55 and above 55, I guess what you can say is that people with higher ejection fractions probably have a mixture of restrictive cardiomyopathies, amyloidosis, and other diagnoses that may not necessarily be as responsive to an ARNI. In addition, patients with really normal ejection fractions and heart failure, they might have valvular heart disease or other reasons for heart failure that shouldn't be really treated with a pill anyway. They should be treated with fixing the valve or whatever caused the heart failure. Below 55%, now you're talking about people with heart muscle disease. You're talking about people with activation of the renin-angiotensin-aldosterone system. And so it makes, I think, pretty solid sense that these are the patients who are most likely to benefit. So that's who I would treat. I would focus on people with evidence for congestion, evidence for structural heart disease, left atrial enlargement, for example, left ventricular hypertrophy, and an EF at or below 55%.
Right. So now we come to the combination of an SGLT2 with an RD. We don't have a large randomized trial to answer this question from whatever is based on the DAPA-HF sub-study, those who are an SGLT2 inhibitors. So we can't say if they are complementary to each other. What is your guess that if there is a trial conducted now, would they be complementary, RD and SGLT2 inhibitors combined? Will they produce an outstanding benefit, much more than ever expected? What is likelihood of such a benefit? Because we don't know whether just using an SGLT2 and just using an RD may produce the same kind of benefit, because the data is from DAPA-HF sub-study, not from a large randomized trial of combining these two agents.
Yeah, wonderful question. All of our data in this regard are retrospective. So the DAPA-HF study, the EMPEROR-Reduce study, we have now, several hundred patients. So in DAPA-HF, it was around 500 patients. In EMPEROR, it was even more, where we were able to retrospectively examine the benefits of SGLT2 inhibitors when they were added to an ARNI. And the benefits were present in patients who were on an ACE inhibitor, ARB, or if they were taking an ARNI. So the relative benefits were the same. This doesn't mean that SGLT2 inhibitors should be used instead of an ARNI. It means they should be, at least based on these data, that they should be used together. Do I know if we're going to see any randomized data for whether or not one or the other might be good enough? No, I don't think that we will see that. It's I think, logical enough to suggest, however, that these drugs have such different mechanisms of action that it's really consistent with what we would expect, that they are beneficial when added together. And so I don't think that it's an either or. I think it really, is important to emphasize to clinicians, particularly given how easy it is to add an SGLT2 inhibitor to this setting. I think it's reasonable to suggest that they should be used together.
So I'll ask you another practical question, that what we do is that at discharge we have ARNI on, we add SGLT2 inhibitors at discharge and send the patient home. A beta blocker we reserve for him to come back in a stable state. Let's say he comes back after 10 days to follow up in the clinic, and we have not escalated the dose of ARNI. Would you like to escalate the dose of ARNI, or would you like to get beta blocker low dose on him now, or would you wait for a beta blocker for more time, and what choice of beta blocker at that stage?
Excellent questions. Out of the four major classes of drug that we use, beta blockers, RAS inhibitors, so ARNI as the front line, a mineralocorticoid blocker, and an SGLT2 inhibitor. Out of those four classes, the one class of drug that is very dose dependent is for their benefits is our beta blockers. So it's critically important that they be added. Furthermore, out of all of the medicines, the one that you want to try to get to the highest tolerated dose is in fact the beta blockers. So if you had to choose, the key is to get all four classes started and then titrate the beta blocker up to target when the patient's not congested. That's my usual strategy. Obviously, the goal is to get all medicines to target. SGLT2 inhibitors, they are at target immediately when you start them, so they're done. Mineralocorticoid blockers are pretty close to target almost immediately as well. So really, ultimately, it comes down to beta blockers and ARNI. So we try to get our patients to the highest dose as possible whenever possible. If I had to choose, I would get beta blockers as high as possible. When I use a beta blocker, if the patient is hypertensive, I'll use carvedilol. If the patient is normotensive, I'll use carvedilol as well. If the patient is borderline in their blood pressures, I'll use metoprolol succinate. We don't use bisoprolol in the United States, so whenever possible, because that's where most of the data are, I try to use carvedilol. But if the blood pressure is a problem, then I'll use metoprolol succinate.
Now, my next question is that we have a warning with SGLT2 inhibitors that they should not be used in acute illnesses because the fear of ketosis. Now, acute decompensated heart failure is an acute illness. Patient has been through the stress of acute. So what do you think? Is it going to be safe to start SGLT2 inhibitors so early?
Yeah, it'll be safe. And there are a couple of important points to make there. Thank you for bringing up ketosis. First of all, in studies of chronic heart failure, there were 0 cases of ketosis. So in the Emperor Reduced study, for example. So although ketosis is a problem in patients with diabetes treated with an SGLT2 inhibitor who get sick, for example, in non-diabetic patients, that risk is essentially negligible. In addition, while you are absolutely correct, acute heart failure is a potential risk for ketosis in patients with diabetes treated with an SGLT2 inhibitor. What we typically recommend is to wait until the patient is stabilized before adding the SGLT2 inhibitor in an acute heart failure situation. What we have not been doing is stopping the SGLT2 inhibitor if someone is taking it and they're admitted with acute heart failure. And we've not seen any cases of ketosis in that setting. Now, of course, if a person is really critically ill, that's a different story. If they're in cardiogenic shock with tissue hypoperfusion, Sure, I think it's reasonable to discontinue an SGLT2 inhibitor, and I certainly wouldn't add it in that setting. But most patients that are wet and warm with with relatively preserved tissue perfusion, I think it should be perfectly safe.
We have 3 minutes exactly left, and my last question is a little tricky. I know it will be a personal bias because I am very confused whether to use dapagliflozin or empagliflozin for heart failure patients, because the two trials have something better on one side, something better on the other side. So what's your personal choice? And how do you decide?
I can answer this one in less than 3 minutes. There's no difference. If you look at, trial-to-trial comparisons, the differences in results are explainable on the basis of the inclusion criteria for the studies, the baseline characteristics of the studies, and very importantly, when you look at, for example, the DECLARE TIMI-58 study versus the EMPA-REG outcome study, so these are diabetes cardiovascular outcomes trials, you see that in fact empagliflozin had the mortality benefit, whereas dapagliflozin did not. So depending on the trials, you get very confused. It's really risky to try to compare studies without really taking a deep look at the differences in the study designs and the patients that were included. So in EMPEROR Reduced, for example, we included a much higher risk patient population. They were older, they had higher natriuretic peptide values, they had more diabetes, they had better medical management with more ARNI use. And so when you look at the two studies, what we can say is that in DAPA-HF, a relatively lower risk, earlier in their heart failure journey population, you saw a mortality benefit, whereas in a more thoroughly treated, more chronically ill population, yes, we hit our primary endpoint. We didn't power for mortality, but we didn't see a CV death reduction in EMPEROR. What that says, most importantly, is get the drug started earlier in the heart failure journey in order to get the maximum benefit. So whether you use DAPA, whether you use EMPA, that's the most important message.
Thank you, Professor Januzzi. It was such a wonderful talk and a discussion, but I can tell you that there are a huge number of people logged on, and I can clearly tell all these people who are logged on that I learned a lot, and I'm sure many of them would have learned much more than what I would have learned. It's really a pleasure to have you. Dr. Hari Krishnan is here, so I would pass on the mic to Hari Krishnan for his final comments.
Thank you. That is a wonderful session, and I think people have really enjoyed the session. I think many of the practical points and the practical doubts have been cleared. Wonderful session. Thank you once again.
Professor, I can tell you there are at least 5,000 who are logged on.
Yeah, currently 5,000. We have 7,000 logins. I think it is one of the best attended meetings in India so far. We had a one-time start and a one-time conclusion at exactly 10 o'clock, probably because of the pre-recorded the talks worked for the keeping the time. So that is exactly the bell has gone. So thank you everyone for having the wonderful presentations, and I request all of you to join tomorrow at 5 p.m. We will start with again a adjunct symposium, and 6 to 9 we have the main session, and again 9 to 10 we have a very useful similar symposium like this. We have 3 halls, hall A, B and C. We have the nurses and the rehab program also running in hall B and C at some point in time. And one more request to the participants, please post questions, because this time there was some difficulty in posting the questions. We have corrected all those problems, and now we will be able to, you will be able to post the questions. So thank you everyone. Good night. Meet you tomorrow at 5 p.m. Thank you so much.
Thank you.
Thank you.